Good afternoon, everyone. Welcome to our respiratory system focus session. I'll go ahead and get started. So respiratory is not a very anatomy heavy subject or topic that we have compared to some of the other ones that we've run into. Um, where it becomes a little more complicated is just some of the theory or the physiology behind it, kind of how things work. And then also applications in terms of what different things could change in your environment that affect your respiratory rate, your ability to exchange oxygen with CO2, that kind of thing. I'll kind of cover those a little bit more towards the end. For now, I'll just kind of discuss about how things are broken up in the system, and then we'll go into some of the theory that I've seen get students during the exam. First of all, we have our divisions. We've got our conducting and respiratory divisions. Both of these are more of anatomy, specifically how oxygen or how our body gets oxygen from the air. So the conducting division is all about getting air into the alveoli. So basically, when you start breathing in, all the way until it hits your bronchioles in the lungs, that's part of your conducting division. And then respiratory division, that is where air is brought in so that they can perform the oxygen and CO2 gas exchanges. One thing about it, the respiratory division is also part of your kind of the shift between ventilation and respiration. So respiratory division and respiration are kind of tied in together. So once oxygen gets into your bronchioles and makes it all the way into the alveoli, that's all considered your respiratory division, where respiration can occur. And then you have your two tracks. We have our upper and lower respiratory tract. For the most part, everything above the larynx is considered your upper respiratory. That includes your nose, your nasal cavity, and your pharynx. And then the lower respiratory tract is considered anything below the larynx, including your trachea, bronchi, and lungs. If you do Google this or look at some different articles or different scientific documentation, depending on what you read, they might cut off the upper and lower respiratory division differently. So say that they might group the larynx in upper respiratory, whereas others might group the larynx in the lower respiratory tract. For the most part, this is the breakdown that we want you to know in this class. Just understand that some of the science behind it, it's not clear cut where it splits off because it combines together into one whole pipe. And so where it breaks apart between upper and lower respiratory is something that's still up for debate in science. But for the most part, this is how we want you to break it apart in this class. Just know in the future classes, they might have you break apart the upper and lower respiratory tracts differently. Okay, so now we have different theories. We have the ventilation versus respiration portions. So ventilation is just bringing air in and getting CO2 out with the air. So inspiration, we have different types of inspiration and expiration. We have our involuntary or non-forced, where it's just our normal breathing in and out while you're sitting or you're kind of doing your normal tasks. Inspiration involves both the external intercostals and the diaphragm. And when you force inhalate, that also involves your scalings, your pectoralis minor, your sternocleidomastoid, and your erector spina. And then for expiration, the diaphragm and external costals, again, they're part of, they help us relax in the non-forced state. But you also include the internal intercostals and abdominal muscles when you force an expiration. The way I've seen this question broken down in the exam is it'll be kind of like select all that apply kind of style. And it might ask you, hey, select the muscles that are involved with forced and non-forced inspiration or only forced expiration. So having a running list of which muscles are included in each of types of inspiration and expiration will kind of help you with that question. I've only really seen one or up to two of those questions on the exam. So you might get asked a question on forced inspiration and then on non-forced expiration, or some kind of combination like that. So just prepare for that, kind of giving you a list, kind of show you the muscles that are involved to kind of prepare you. And then also know your pressure gradients. So what is intrapulmonary versus intrapleural pressure? And then the other part is understanding Charles' law, which is just um, pressure is inversely proportional to volume. So if I have less volume in my lungs, then my pressure will increase, and vice versa. If my lungs expand, i.e. the volume expands, the pressure in my lungs decreases, which allows air to kind of come into my lungs. Um, and then my other example of when volume decreases, that increases the pressure in your lungs. The pressure in the lungs can be higher than the outside pressure, and then air will go out or expirate. And then respiration. Respiration is primarily gas exchange between CO2 leaving the blood and oxygen coming into the blood. Respiration occurs in three different places. So I want you to think about a normal air molecule that you just breathe in. The first place it'll go will be in our alveoli. We call this external or pulmonary respiration. So the oxygen from the air will get into the alveoli. The CO2 will leave the blood and go back into the quote unquote air that you're going to expirate. And then the oxygen goes into the bloodstream and then it gets circulated. So once it leaves the lungs, and starts going to all your tissues, we call this internal or systemic respiration. And then this is where as the blood kind of goes through, I'll just pick an organ. Let's say my kidney, for example, or my intestines. As the blood kind of goes through there, it'll start delivering oxygen to the tissues while also picking up CO2 that our tissues are releasing. And then that blood will then come back into the lungs, release the CO2, take in more oxygen, and then can go back into the organs, or into the tissues to deliver that blood. The oxygen that gets dropped off in the tissues then makes its way to the cells. And in the cells, we have what's called cellular respiration, where the cells can then use that oxygen to help convert energy from food into ATP. Um, you might get asked a little bit about cellular respiration on the exam, maybe like a question, but the big ones are the external and internal respiration. Primarily, what gases are being exchanged and where, when it comes to respiration. Okay, neural control. This is at least a question on the test, maybe two, from what I remember. So neural control, we have different ways of controlling our breathing. First of all is involuntary control via medulla oblongata and the pons. That's our normal, you're just sitting here. You don't really have to think about breathing. It just happens. The body knows that, hey, you have a buildup of CO2. I need to get rid of it. So let's just breathe to remove that CO2 and get more oxygen in. And then we have our voluntary control where we actually think about breathing or like, oh, I feel a little, I need a little bit more air. So you kind of force yourself to inhalate or exhalate. That's all done by the motor cortex, that's in the brain. Um, Voluntary control does have some limits. So the thing about the idea of holding your breath, you can't just keep telling your body to hold your breath. You'll try maybe for a couple seconds, depending on how good you are, maybe up to a minute. Um, but basically what ends up happening is that the medulla oblongata is getting sensory information from your body saying, okay, CO2 is building up, CO2 is building up. I need to get rid of this oxygen, or I need to get rid of this toxin and get some more oxygen in. So after a while of you trying to hold your breath in, the involuntary portion of your body, the medulla oblongata and the pons, will just take over and force the breath, or you know what I mean, will force you to take a breath in and exhale. Um, it is a voluntary control is very limited because the body is constantly getting fed updates on how much CO2 and oxygen and pH, how those levels are in your blood. How this gets felt in your body is through chemoreceptors. I'm throwing the word chemoreceptors out here because I have seen this question get people, they just don't pick the right type of receptor. So it is a chemoreceptor or a chemical receptor. So in your aorta, your aortic bodies, and then your carotid bodies here in your carotid arteries, there are sensors that determine how much oxygen and CO2 and pH is in the blood. The reason they're located in these locations, if you think about it from the flow of blood, blood leaving the aorta should be the most oxygen-rich blood that there is. It just came out, you just did the external respiration in the lungs. This blood now should have the most oxygen available. And so the body can sense at this point, okay, how much oxygen is in this blood? And is this going to be enough oxygen to then deliver to all my tissues? Do I need more? Do I need to increase my heart rate to get more oxygen? Because what I'm getting right now coming out of the heart is not enough. And then in your carotid body, remember this blood, especially if you could think about what this is pointing to is the internal carotid artery, which if you remember, this kind of goes to the to your brain. Um, your brain needs oxygen. It's going to consume the most oxygen in your whole body. So this senses whether your brain itself is actually going to be able to get enough oxygen and whether the heart needs to, um, increase in heart rate if you need to increase your respiration to then get more oxygen to the brain. So again, this is done through sensors in the aortic bodies and the carotid bodies. Or you might see in the exam as the aorta and then the common carotid artery or something like that. Um, so just this neural control question, I expect at least one question on this, maybe two or three. One of them could be where are the where are the receptors that feed back to the medulla oblongata, your CO2 rate or CO2 concentration? And you would say, okay, I have them in the aortic and carotid bodies. Another question would be what type of receptor feeds back to the medulla oblongata? And you would say chemoreceptors or chemical receptors. And then this is in your notes. I've never seen a question on this, but you could always get one. Is the medulla actually has a sensor directly on it that helps regulate to sense your cerebral spinal fluid, and that lets it know whether you're getting the right pH, CO2, and oxygen. Okay, this is the one that I really wanted to talk about. Once I describe this to you or explain it to you, hopefully this kind of makes a little more sense. So you have oxygen hemoglobin dissociation. What this is basically a measure or a curve of how well hemoglobin will, I guess, hold on to oxygen. That's probably the best way I can describe it. So let's say I'm hemoglobin, let's say it's my hand and I'm like gripping a ball of some sort. Um, if I um, make a couple changes in my body, um, I will have a more or a tighter grip or not as tight of a grip on the ball in my hand. And that change in grip will make it more likely for me or least likely for me to release that ball. And that's all this distribution curve is. It's what factors can change how well hemoglobin can carry or hold on to oxygen. So these are three examples that I put on the left. These are the most common examples. You might see some different examples on your exam, but hopefully as I describe these, they'll make a little bit more sense. So let's think about these three different situations. So how does exercise, higher elevation, and fever affect this curve right here? So let's think about exercise. So if I increase my exercise, or if I start exercising, one of the first things that's going to happen is that your body temperature is going to go up. You're going to start um, releasing heat from your muscles as they start working out. So because your body temperature is going to go up, um, that's like one. Your muscles will also start releasing CO2 because they're breaking down that energy that they have in the cells to be able to meet your exercise goals, whether that's your running or your weightlifting, whatever it might be. As that CO2 gets released in the muscles, there's going to be more CO2 that gets absorbed into the blood, which causes pH to go down. So CO2 is acidic, and so remember, pH is a um, indicator of the amount of hydrogen atoms that you have. And so by having more, or indicator of how neutral or alkaline or acidic your blood is. So the more acids that get released into your blood, the lower your pH will go down, will change. So let's think about the curve on the right. So my body temperature goes up, so increase in body temp. Your muscles are releasing CO2, so I'm going to be releasing CO2, or pressure of CO2 will come up, and then my pH will go down here. That causes the curve to shift to the right. The way the exam is going to ask you this is it's going to give you a scenario or some indicators like temperature or CO2, etc. And it'll just ask you like, which way do you think this curve is going to shift? And you might be given like four options. Really, if you think about it, this curve could do one of three things. It can shift left, it could go to the right, or it could not change at all. So if there's a fourth option that kind of looks weird, that's not one of these three, I would just ignore it. So instead of guessing one out of four choices, really it's one out of three. Did the curve go left? Did it stay the same? Did it go right? And so when we tell if we start exercising, you're going to have a shift to the right, decreased affinity for CO2. So what's going to happen is because you're using up all this energy and because you're releasing more CO2, hemoglobin is not going to hold on to oxygen as tightly. So as you get oxygen in from your breathing, it's going to release it much sooner to get that oxygen to your cells to then get that energy so that they can continue doing whatever work they're doing or to repair themselves. Okay, next scenario, higher elevation. So, not sure if you guys know this, here in Phoenix, we are actually at elevation. We're about, I believe it was like 1,000 feet above sea level, something like that. So at sea level, there's a certain pressure that the air puts on our bodies. Roughly that's around 14.7 pounds per square inch. Um, and then as you go higher elevation, there's less pressure being put onto our body. So if you remember how we talked about how we breathe, and so me exhaling, it's a increase of pressure in my lungs is higher than the pressure outside or in the natural air. So if I go to a higher elevation, there's less pressure outside, so I am more likely to um, breathe more out. And um, it's kind of like a really weird relationship. So it's easier for me to ventilate out or to expirate, but and it's easier for me to inhalate. However, because I'm so high in elevation, there's less oxygen. So what ends up happening is your body starts breathing more to kind of get the same amount of oxygen. You see this with like athletes, or if you've ever gone to high elevations, your breathing becomes harder because there's less oxygen for your cells to exchange with. And so it needs to breathe more or take in more air to get the same amount of oxygen that you would at home, for example. So higher elevation, you're going to have a lower atmospheric pressure. You're going to have an increase in ventilation. So what's going to happen is you're actually going to be expelling more CO2. So that's going to have a decrease of CO2. And what's going to happen is your pH is going to increase as well. And so, and that's because you're releasing more CO2 out of the body, so you're more alkaline or less acidic now. And it's going to cause a shift to the left and an increased affinity for oxygen. Um, what kind of happens is that your hemoglobin is going to hold on to the oxygen more. Um, this one's kind of like an interesting one where like exercise makes sense. Decreased affinity for oxygen, you're going to release more oxygen. Um, for the left shift, for the holding on to the oxygen more at high elevations, that's more to do with like the overall environment that you're in. Um, especially with like a higher pH and a higher CO or and a lower CO2. The hemoglobin will just hold on to the oxygen tighter, which also helps or also makes you feel like you're not getting as much oxygen. The long-term effects of this is that your body is actually going to adapt. This 2,3-DPG, that's a chemical. You don't have to know it for this class. Just know that your body produces this chemical, and what it does is that it attaches to hemoglobin so that it is more likely to release oxygen. It's kind of like a tag, and so it your body will produce this when you need more oxygen to then attach to the hemoglobin so that the hemoglobin will release that oxygen easier. And so what ends up happening to you long term at higher elevation is that this left shift will then start going back to the middle to where your new normal is at. Um, and again, you can visualize this by exercising at elevation. If you ever lived in high elevation or you hear athletes going to like Colorado to train, the whole idea of training at higher elevation is that you're training your body to be able to do the same job with less oxygen. Um, and like I mentioned, this left shift will go back to the middle once you've trained enough. What ends up happening is now you go back to lower elevation to like a marathon. Now all of a sudden your sh curve shifts to the right, and now your body's able to release oxygen more efficiently. And now all of a sudden you're like able to just power through some of these exercises because your body is already your muscles are trained to work with um, a little less oxygen, but you've also made more red blood cells to produce the oxygen that you need. So now you have extra red blood cells. You now have a decreased affinity for oxygen because you just trained so long that you actually have a high level of DPG, and this causes a right shift. There's a lot of different like theories behind this, but biggest thing to note is that initially you're going to have a left shift when you go to a higher elevation, but over time you'll just go back to the center because that becomes your new normal. And then the last one is fever. Fever is pretty easy. If you get this one, it's fairly simple. A fever causes the body temperature to increase, which will do a right shift of the dissociation curve and allow the oxygen to be released more easily where your body can use it for immunity or also to help repair cells. Hopefully this talk through kind of made sense in a way that you can put it together on the exam. Again, you're not gonna be expected to draw this. The majority of the questions I see for this curve are, I'm gonna give you a scenario and you tell me whether the curve went left or right. Um, so you can kind of see the three examples I showed you on the left. I showed you an example, really two examples of the curve going to the right, and then one example of the curve going to the left. Um, these might be the ones that are on the exam, or there might be some that are similar. Um, but just prepare for that. You're going to have a few of these. I'd expect at least two, maybe up to four questions asking you this because, again, I just gave you three scenarios. I could give you all three scenarios on the exam, so that's three questions. Plus, let's say Dr. Curley adds one or two of her own scenarios. And so just prepare for this one. I don't want this one to get anyone because it seems to get people every semester. And when you talk it through like this, it becomes easier to understand which way the curve is going. Okay, that's all I really had for this one. So again, good luck on your exam. If you have any questions, please reach out via Canvas. Um, and other than that, I'll see you guys next week.